then there was no really clear indication. I just want to see if you guys sort of feel, that we could see it all. Versus that we don't need any PDR. There are the two reasons I couldn't see any all figure. So that's like 90-ish-year-old data as well. So those are the research which is what I love.
Okay.
But this is part of it. I mean, if they go into the consumer, that's okay, but I think it has to be documented.
Okay, I'm going to start now. Did everyone get the pre-work? I think it was sent out to all of you by someone called Rory. Did anyone get it? Okay, great. So you should all have the worksheet. So I'll just get started. I'm also recording this session, so just to make you aware. So today is the second session. Just let me know if you want to ask any questions in the chat box or put your mic on and ask away. So today's session is on pharmacokinetics, and it is the second session out of 4. So today we'll be talking about what pharmacokinetics is and why it matters, and why as pharmacists we study it and why we look into it. From my understanding of your curriculum, you don't actually get much or any pharmacokinetics teaching. So I think I will be treating it as sort of like a baseline for you to learn a bit about it and why we use it. So the core principles of pharmacokinetics is what I'll be talking about. So those are things like absorption, bioavailability, first-pass metabolism, distribution, volume of distribution, metabolism, things like half-life and steady state. These terms, if you're not already familiar with them, will become more familiar as we go through the session. And then using the worksheets that I sent beforehand, we'll be doing some case studies later. So firstly, I'll just talk about what pharmacokinetics is. So pharmacokinetics is a branch of pharmacology, and it studies the time course of a drug concentration in the body after dosing. So basically what happens to the drug after we have either ingested it or we've injected it, or if it's like a patch that we've put on the skin through transdermal. If it's a spray, if it's an inhalation, what happens to that drug once it reaches the body. So the 4 main processes involved, we abbreviate that to ADME, and that is absorption, so how we get it inside our body, the distribution of where it will go and where it's transported, metabolism of the drug, so how it's broken down, is it broken down in the liver, in the kidneys, and then excretion of it, how does it leave the body. So pharmacokinetics, what it's used for. So why do we study in depth what happens to the drug? So we want to establish, so for every single drug, they all work differently. And once they reach the body, they all work through different mechanisms, and some need to be given locally, some need to be given systemically. So to a point, the pharmacokinetics will tell us the routes in which it can be delivered through, whether a loading dose is required, or we can just start with a maintenance dose. The dosing interval, so does it need to be given once a day or 3 times a day? Whether we need therapeutic drug monitoring, so some drugs like gentamicin, we need to have TDM monitoring, so making sure that the level is within a certain range, the plasma concentration, so that we don't get any toxic effects or we get an effect, a desired effect. We also study pharmacokinetics to see if we need to alter any doses, if a patient has any kidney impairments, so renal impairments, or any hepatic impairment. And then where we do have these dose alterations, are there any other drugs present? Are there any interactions between them? So pharmacokinetics is basically like a model to see the likelihood of what is going to happen to the drug once it's given to the patient. And then it allows us to determine all of the things that are listed that I've just gone through. So absorption. So absorption is the process of a drug traveling through where we've given it to the site of administration, whether that's like topically through a patch, orally or via injection, and how it gets into the systemic circulation. So unless we're giving a drug via the IV route, all other drugs need to be absorbed into the plasma, which obviously includes crossing several membranes, and so we need to dose correctly. So the absorption depends on many different factors, not all just how the drug is administered, but to get to the site of administration. So an important factor for absorption is the bioavailability of the drug. So I'm not sure, are any of you familiar what bioavailability means? You can write it in the chat box if you are, or you can guess what you think, make an educated guess. Okay. Well, I'll go through what bioavailability means. So bioavailability is the amount of the administered dose that reaches the systemic circulation. So let's say all IV drugs have 100% bioavailability. So the dose that is in that syringe will go straight into the plasma immediately and directly, and so you have 100% bioavailability. Whereas if you give a drug orally, then it's more than likely to have less than 100% bioavailability. It will never get up to 100%. It could probably get quite close, but it will never be 100%, and that's because the drug has to pass certain membranes. So if it's given orally, then it has to pass the GI tract. So this is and then when it's absorbed, it will go into the hepatic portal vein, and all of this is called first pass metabolism. So it's not just straightforward that you give them the drug and it goes straight into the blood. It has to cross several membranes, and the most common is first pass metabolism, and that happens when you give a drug orally. And that's why you don't have 100% bioavailability. So bioavailability is really important because it accounts for why oral doses are often higher than an IV dose, and also why some drugs just can't be given orally. So examples include clarithromycin. So we never really give clarithromycin via the IV route, and that's because the bioavailability of IV clarithromycin and oral clarithromycin are practically the same. They're bioequivalent, and therefore if we don't need to give something through the IV route, then we don't have to. So it prevents, there's benefit from that, just because it can be painful to give something IV, can be irritant to the veins, and we must always prescribe clarithromycin orally, just because of the bioavailability. The only reason why we wouldn't is if the patient is nil by mouth. So another drug, for example, insulin, we never give this orally. That's always given by a subcutaneous injection. The reason why we can't give it orally is because it's inactivated by the stomach acid, so that first pass metabolism if we gave it orally, there'd be no active drug left. So orally, it has 0% bioavailability, and therefore we always give it by subcutaneous injection. Things like glycerol trinitrate, so GTN, taken orally crosses the GI tract well, but it's almost completely metabolized in the liver, so during the first pass metabolism, and therefore, again, it's like got 0% bioavailability, and that's why we give it through other routes. So, you know, when you tell them to spray it under the tongue, sublingually, or it can be given transdermally. On the other hand, vancomycin is always given through the, well, nearly always given through the IV route, and that's because it's got a really poor oral bioavailability. But there is one indication as to why it would be given orally. Does anyone know what the indication is to give vancomycin orally? Yeah, exactly, Catherine. So the only reason why we would give vancomycin orally is because of C. diff, because that is the localized area of the infection, and that's where we want to target the drug. That would be the only indication. So now if we look more into bioavailability, different formulations can have different bioavailabilities. So this, a good example of this is oral digoxin. So digoxin comes in tablets and liquids. However, there's a difference in bioavailability between the formulations. So a liquid has 80% bioavailability, whereas tablets have 70% bioavailability. And it also becomes apparent in some different brands of drugs. They sometimes have different bioavailabilities. And this is why for some specific drugs, they ask you to only prescribe by brand. And this is because of that difference of bioavailability. So examples of these drugs include theophylline, modified release, a lot of the anti-epileptics, so phenytoin, carbamazepine, and phenobarbital. So it's really good to just have that in mind when you're prescribing, especially if they have, like they've come in on a drug history medication. So you should check whether, firstly, if we stock that brand. So normally you can ask your ward pharmacist. But also you can look these things up yourself on the BNF, especially if it's like out of hours. So if you're on a night shift and you're clocking someone in and you have to prescribe their medications, then having a quick look on the BNF to see if it has to be brand prescribed, and then making sure you prescribe the right brand just because of the bioavailability. So we have our first case. So on that worksheet, if you want to do the first question. So I believe the first question is, what dose of digoxin liquid should you prescribe to give an equivalent dose? If everyone wants to try that. Yeah. I'll give you like a few minutes. Okay, I can see one answer, but I'll just give everyone else like a few more minutes before I go through it. Okay, so let's go through that. So the question was, Mr. BC, 43 years old, is admitted following a CVA. He's unable to swallow, therefore has an NG tube inserted. Within his drug history medications, there's digoxin, which now needs to be given as a liquid preparation. He was admitted taking digoxin tablets at a dose of 125 micrograms once a day. What dose of liquid should you prescribe to give an equivalent dose? So, let's go through that. So 110. So I'm not too sure about the units. It's not milligrams, but 110 would be correct. And this is how we go through it. So you have the tablets, which is at a dose of 125 micrograms, and the bioavailability of the tablets is 70%. So you would do the 125 micrograms times by 0.7, and then we have an X, which is the strength, the dose that we're looking for. Then you times that by 0.8 because the bioavailability is 80%, and therefore these two should be equivalent. So then to find out the X, we would do 125 times by 0.7 divided by 0.8, which equals 109.375 micrograms, which obviously we wouldn't really give in practice, so it would be 110 micrograms as the liquid. Does everyone understand that? Does anyone need me to go through that again? Or is that self-explanatory? Okay, should be fine. So if you want to do the next question, 1B. Okay, do you want to explain how you got there? Do you want to put your microphone on? You can tell everyone how you got there.
Yeah, sure. Can you hear me?
Yeah, I can hear you.
Yeah, so BNF says 20 to 30% on converting from IV to oral.
Mm-hmm.
So the tablets come in two forms, 125 micrograms and 62 point something. So if we use 125 micrograms and then
Yeah.
half of 62 and a half, that would come about 30% increase. So,
And that's how you got there?
Yep.
Okay. Yeah, you're right, as in it is 187.5 micrograms in total just because of the tablet size. But I will go through the specific calculation. So 125 micrograms is given, IV delivers 125 micrograms into the circulation, but if given orally, only 70% of the dose reaches circulation. So 70% equals 125 micrograms. Therefore, to get the same amount reaching the systemic circulation, you would have to do 125 divided by 70 times by 100, which is 178.57 micrograms, and then the equivalent dose, because of the tablet size, would be 187.5 micrograms. So
is it
everyone
100% bioavailability by IV? Because
Yeah.
BNF says 20 to 33% increase.
So in the BNF, it depends on if they're converting from a liquid or if they're converting from a tablet, because the tablet is roughly 70% bioavailability and the liquid is roughly 80% bioavailability, but each brand varies. So I guess the BNF has to take into account all of the different like tablets or liquid and then the different brands. So it just gives you a rough estimation.
Right.
But yeah, for this example, it's going from tablets to from IV, to the tablets, and IV is always 100% bioavailability. So that's how you'd work that out. Anyone else got any questions about that, or am I okay to move on? You're all very quiet. Okay. Move on. Okay, so using the BNF, which of the following drugs should be prescribed by brand, as bioavailability may vary considerably between preparations? So if you all get the BNF app up, or if you're on your laptop, check the BNF. Which one of these drugs must be prescribed by brand? Just type it in the chat box. Why do you think carbamazepine needs to be prescribed by brand? There's also one more that also needs to be prescribed by brand. Epilepsy, yeah, okay, you're right that they're all anti-epileptics, but there are different categories of anti-epileptics. So carbamazepine, you're right, it does need to be prescribed by brand, but that's because it's in category 1, whereas levetiracetam is in category 3 and does not need to be prescribed by brand. There's no difference in bioavailability between formulations, so that can be a straight one-to-one switch. But there's one more drug on that list that needs to be prescribed by brand. Anyone know the last one? Do you know where to look on the BNS, where it should say whether it should be prescribed by brand or not? Yeah, Hannah, you're right, it's nifedipine. So in the BNS, under prescribing and dispensing information, that's where it will say if it needs to be prescribed by brand or not. So for nifedipine, it says different versions of modified release preparations may not have the same clinical effect. To avoid confusion between these different formulations of nifedipine, prescribers should specify the brand to be dispensed. So that's where you would have a look under prescribing and dispensing information. Okay, I'm going to move on. Okay, so now we move on to distribution. So once the drug has been absorbed into the systemic circulation, it's then distributed around the body. So there are different places and different compartments that the drug may distribute into, depending on their physiochemical properties. So this is like, does the drug go into the plasma as a free drug? Does it get bound to plasma proteins? Extracellular fluid, does it go there? Does it go into the muscle, fat? Does it go to the CSF? Does it deposit in the bones? So there's loads of places where the drug could go, and we need to study as to where it gets deposited. So this is a little example of the plasma and then the fat. So some drugs show very little distribution into other compartments and are mostly confined to the plasma. So this could be either as a free drug or bound. So these, the plasma is in red, and then you have these purple molecules which are plasma proteins, and then you have blue, which is the free drug molecule in the plasma. So if the blue and purple are together, that means the drug is bound to the plasma protein. So drugs that exhibit this behavior tend to be quite large, hydrophilic, which means kind of like water-loving, and so yeah, large and hydrophilic, and that's why they like the plasma. In contrast, you have other drugs which quite like to be in the fatty compartments. So this leaves very little drug in the actual plasma. Drugs that exhibit this behavior tend to be quite small, lipid-soluble molecules. So yeah, they're quite the opposite to the other molecules. They're lipid small and lipid soluble. So then this is an example of warfarin. It's an example of a drug that remains within the plasma and extensively binds to plasma proteins, usually albumin. So drugs that show limited distribution have small volumes of distribution because they're confined to the plasma. Whereas drugs like diazepam distribute extensively into the fat, so you see this in the yellow compartment. Tetracyclines distribute extensively into the bone, which is why you can't give it to children because of those side effects. And theophylline distributes extensively into the extracellular fluid. So the volume of distribution that I've been talking about is a theoretical value. So it's the amount of plasma that would be required to hold the total amount of drug administered if it were present only in the plasma. So basically, if it didn't distribute anywhere else in the body, it only stayed in the plasma. So why do we use volume of distribution? So it's useful for telling us about distribution characteristics of the drug. So, for example, if we had a very high volume of distribution, then we would assume that there's extensive distribution into other compartments, that the drug isn't just confined to the plasma, it goes into different areas like the extracellular fluid, it could potentially go to the bone, it could go to the fat, different parts of the body. But equally, if we have a low volume of distribution, then we can assume that it's mostly confined to the vascular compartment. And so volume of distribution is key when we're calculating if we need a loading dose required to achieve a desired blood concentration. So some drugs do and some drugs don't, and that is dependent on their volume of distribution and where the drug distributes to in the body. Is everyone with me so far? Yeah. Continue. So dosing on body weight for drugs that don't distribute into fat. So dosing for a number of drugs is weight-based, but if a patient is overweight and the drug you're using does not distribute well into the fat, you don't want to include this compartment in your dosing, which makes sense because if all the drug is within the plasma, then it's really irrespective of what the patient weighs because it doesn't distribute into the fat. So to do so would result in a higher than required dose, which can have obviously severe consequences for the patient, especially if the drug has a narrow therapeutic range or has some dire side effects. So things like theophylline and gentamicin. So I've got some diagrams which should depict how this all works in the body. So let's imagine this is a theoretical situation. We have drug A that's dosed at 1 milligram per 15 kilos. And our patient A, so the one on the left, is 60 kilos, which is a normal, healthy patient, and is a normal, healthy weight for their height and their gender. So their dose will be 4 milligrams because they're 60 kilos and the dose is 1 milligram for every 15 kilos. So their dose is 4 milligrams. And let's imagine each of the circles represents 1 milligram of the drug. And so in this patient, the drug is distributed out fairly. So in the patient next to them, in the middle, we have a slightly overweight patient, 120 kilos. And again, we want to give this drug A to the obese patient weighing 120 kilos. But if drug A distributed well into the fat, we can safely dose the patient on their actual body weight because we would have drug molecules in the fat and we would have drug molecules in the plasma, and it would be equally distributed in the whole body. As we know, a lot of the drug will end up in this fat tissue as well as being in the plasma. So there won't be any unwanted effects because it would have an equal distribution. But then, lastly, in the last patient on the right, again, they're 120 kilos. But in this situation, drug A doesn't distribute into the fat, so it only goes into the plasma. But if we dosed based on the actual body weight, then they would be getting an overdose just because we're accounting for the fat that they're carrying, but none of the drug is being distributed into that compartment, and therefore they would be getting a massive overdose. So I feel like these diagrams are quite good in representing what I mean by different compartments in the body and why we use weight-based dosing and in some drugs and why we don't in others. Oh, I think there's a question. If a patient weight is high due to edema, you still use weight? Yeah, that's a really good question. So if a patient has edema, we would sort of use their most recent, we wouldn't use their weight, their current weight, but we would have, well, hopefully on admission, they would be weighed and we'd have like a baseline of their weight. And then we would use that as opposed to their current weight, which is water weight. So no, we wouldn't base it on their water weight. Because, yeah, it would just be water weight and the drug wouldn't be distributed into that. So that would be incorrect. So then when I was talking about therapeutic windows, and we have some drugs which have a narrow therapeutic range and we need to do TDM monitoring, this graph nicely represents it. So it shows that the concentration on the y-axis and the time on the x-axis. So over time, we reach steady state, but for narrow therapeutic range drugs, we need to make sure that it's between the two middle lines in the effective region. So it's effective, but it's not toxic. So there's a range, a concentration, plasma concentration range where it's ideal, but if you go any above this, then it's toxic, and if you're below this, then it's ineffective. And those two lines also have names. So you have the minimum concentration it can be at and the maximum concentration that it can be at. And if you go above this, then it will be toxic and can cause side effects. So examples of this, again, things like gentamicin. Unwanted effects include ototoxicity and nephrotoxicity. But again, if you dose too small for the patient, then it can be ineffective and you won't treat the infection and it could just get worse. So yeah, like I said, gentamicin is a key example of a drug that does not distribute well into the fat, and it therefore needs to be dosed on adjusted body weight. So for any patient who weighs greater than 20% of their ideal body weight, we would normally use the adjusted body weight for patients who take gentamicin. This is because they've got a narrow therapeutic range, and using the actual body weight to dose overweight patients is likely to result in toxicity. And that's because of the diagram that I showed you before. It doesn't just distribute well into the fat, and you would be assuming if you base them on actual body weight that it did, and that's why we use the adjusted body weight. So if everyone's got the micro guide downloaded on their phones or has access to it on like a Trust laptop, do you want to check what the correct gentamicin doses would be for these 3 patients? I'll give you like about 10 minutes to look at them. Okay, let's go through the answers. What have people got for number 1? What should the dose be? Yeah, so the first one we can use normal body weight because they're 60 kilos and it's 1.7 meters tall. Yeah, so it's just 60 times by 5, which is 300. So what about the second one?
Sorry, which weight was it that we did 20% of?
Sorry?
Which were the numbers that we compared to see if it was about 20%?
So that's based on ideal body weight, and well, what I use is in the micro guide under formula. It has like a table. Let me see if I can find it, and I'll show you on my screen. 1 sec. Does everyone have micro guide? Or you can like Google ideal body weight table if you don't. So goes in this table, and then here is the weight. You can see. So does anyone have access to an ideal body weight table?
My micro guy says that there isn't a guidance available for University Hospital Lewisham for some reason.
Oh. Okay, so you might have to just Google ideal body weight table graph, sorry. You can't access it. But I'll go through them anyway. Found a calculator on my comment. Let me turn my screen on. So if you see this on Macros and then scroll right to the bottom, you should see formula like that. You saw that? No worries. Okay, I'll just go through the second one anyway, to save some time. So the second one, it's a female, they're 84 kilos and 1.65 meters tall. So the ideal body weight for a female of this height is about 55 kilos, and therefore she is 20% over 55 kilos. She is 20% above her ideal body weight, because 20% above would be 66 kilos and she is 84 kilos. Therefore, we'd be using adjusted body weight, and in this case, it would be 66.4 kilos. So then we would just do 66.4 times by 5, which is 332 milligrams. That makes sense to everyone. Yeah. Okay.
Yeah,
Then-
because that's. Oh yeah, okay.
Okay. Did you have a question?
Sorry, no, it's fine. Yeah, I read it again. Yeah.
Okay. And then the last one is a male who is 94 kilos and 2 meters tall. For a male of this height, 94 kilos is only slightly above ideal body weight of 93 kilos. Therefore, you can use his actual body weight, and so therefore 94 times by 5 is 470 milligrams. And he is fine to use that. So then we have metabolism and elimination. So elimination is the removal of an active drug from the body, and it's largely made up of hepatic metabolism and renal excretion. So different drugs are eliminated to different extents by the two processes. Understanding which route is the main route means of elimination for a drug is important when making decisions and choices if a patient has renal impairment or hepatic impairment. So we always must take that into consideration. Clearance is a measure of the rate of elimination, which is usually expressed as a volume of plasma cleared in a unit of time. So usually it's mils per minute. And that's how we would measure the clearance of a drug. So then we have half-life and steady state. So the half-life of a drug is the time it takes for the plasma concentration of a drug to be reduced by 50%. And normally, for any given drug to reach steady state, it takes about 4.5 half-lives. And steady state is the point at which levels of the drug are consistent in the plasma. Drugs with long half-lives, where immediate effect is required, usually have loading doses. So then there are these graphs, which you can see some of them have a loading dose and then they have maintenance doses, or they have just maintenance doses and then wait to reach steady state. So you'll have your minimum effective concentration, so the minimum plasma concentration that it has to reach in order for the drug to have an effect. So in the first graph, you have just a consistent dose, and then after about 4.5 half-lives, you see that it's reached steady state, whereas a loading dose is needed in the second one, which leads to a big peak and then falls, and then it reaches steady state after more doses are given. So we need to be really careful that we know which drugs have to have a loading dose and what dose the loading dose should be, because we've had a lot of incidences where things like warfarin, amiodarone, phenytoin, they've all been incorrectly given as loading doses, or even like teicoplanin, which has resulted in a really high peak and can lead to unwanted side effects. So that's why in most trusts, they have a guideline on like therapeutic TDM drugs or drugs that need loading doses, and it will tell you how to dose according to that guideline. So especially when a drug does need a loading dose, you have to make sure there's clear communication between all of the healthcare professionals on the ward. So if you've prescribed a loading dose, normally it's sort of like the first one is a stat dose, and so you need to inform the nurse and the pharmacist just in case it's not stock on the ward. And all the clinical checks are performed by obviously the doctors, and then screened by a pharmacist before it's given. So this is a half-life case study. So the patient is 87 years old. He's been experiencing drowsiness during the morning. He takes aspirin, simvastatin, risperidone, and diazepam. So which drug is the likely cause for daytime drowsiness, and how might you address this? So out of these 4 drugs, which one do you think would lead to the daytime drowsiness? Does anyone know? Have a guess? Okay. Okay. Not sure. Okay, I'll give you a bit more information. So both diazepam and risperidone can cause drowsiness, and the half-life of diazepam is 40 hours, and the half-life of risperidone is 3 hours. So with that information, which one do you think is causing the hangover effect, the daytime drowsiness, if they're both given in the evening? Anyone know? Yeah. So the one with the longer half-life, which is diazepam. So diazepam has the half-life of 40 hours, and therefore is the one causing that hangover effect. So we want to stop this because the patient is very drowsy during the day. So something that we could do is change to a different benzodiazepine. So something for the same indication, but doesn't have such a long half-life. So something like lorazepam has a half-life of 10 to 20 hours, of about 10 hours, and has a shorter half-life. May be used instead of diazepam. Other benzodiazepams that can be used include temazepam or oxazepam. These also have a shorter half-life, but you would consider switching depending on which one you want and the potency, depending on the patient, really, specific to the patient. So this is a phenytoin case study. A patient is on phenytoin 300 milligrams at night. The doctor has taken phenytoin levels and it's come back at 6 milligrams per liter. The normal range of phenytoin is between 10 and 20. What else do you need to know? Like, what questions would be going off in your head? Put them in the chat box. Like, what would you be thinking? Would you be thinking anything? Yeah, when was the last dose given? What else? Time of the last dose? The amount? So have they been given the correct dose? They've been taking it correctly. Any interactions? Exactly. Are they on any other medications? that interact with the phenytoin. What else? Okay, so other things to consider. Phenytoin is in that category 1 of antiepileptics. So what formulation are they using? Are they on the correct brand? Have they been taking their medication at all? What time was the level taken? Because there's specific times a level should be taken. So those are the things that you would be thinking about. So, and also, are they fitting? Because their level has come back low, but clinically, are they having any epileptic? Are they fitting at all? So things about compliance, like I said. So phenytoin is highly bound to albumin in the plasma. So what are the levels of albumin potentially? So the dose is increased to 400 milligrams, and levels 5 days after dose adjustment are 15 milligrams per litre. Patient is discharged but readmitted after 5 days with signs of toxicity. What might be the cause? Okay, does anyone know what the signs of phenytoin toxicity are? Signs, symptoms. Okay, so some of the signs of phenytoin toxicity include like slurred speech, nystagmus, diplopia, and ataxia. So the reason why they potentially might have been readmitted with toxicity is that going from 300 to 400 milligrams is a huge dose increase in terms of the drug phenytoin, and I'll go into why that is, and it's got to do with their pharmacokinetics. But normally, if we're dose adjusting, then we would only so they were on 300 milligrams, we would only go up to maybe 325 or 350. And then we would have to monitor, and usually the level would be taken not just after 5 days, but after about 10 days of phenytoin administration. So it would be given daily for about 10 days and sort of monitoring them before we would be like, okay, fine, their level is in range. So compliance, intentional overdose maybe, or unintentional overdose. So poorly monitored dose adjustment, saturation kinetics, which I'll go into in the next slide, and drug interactions. Are they taking anything else that is increasing the phenytoin level or phenytoin in the plasma concentration? So I talked about first zero order kinetics. So phenytoin displays this. So as you can see, that you should just about be able to see the 300 milligrams a day is just below the minimum effective concentration, but obviously in some patients that is fine. But as we increase the dose, it's got such an exponential growth in terms of plasma concentration that a little adjustment can significantly increase plasma concentration. And so you need to dose increment really slowly and monitor with phenytoin. That's just an example of phenytoin toxicity and what it might look like. So now I'll just talk a bit about drugs and renal impairment. So filtering medications in renal impairments, chronic or acute, extra consideration needs to be taken. If the renally cleared with a narrow therapeutic index, so if the drug is renally cleared and TDM monitoring, renally cleared with dangerous effects in accumulation, and if the drug is known to be nephrotoxic. So drugs cleared by other means or metabolized to inactive non-toxic compounds do not need to be adjusted. So these are, so of all of these drugs, which do you know have a narrow therapeutic margin and could be suitable for therapeutic drug monitoring? Type in the chat box. What do you think? Any of them need therapeutic drug monitoring? Yeah, gentamicin. Lithium, yeah. Digoxin, yeah. Okay, there's quite a few on there. So others include amikacin, which is the same class of drug as gentamicin, aminoglycosides. So digoxin, like I said, lithium, teicoplanin, and the vancomycin. So renal function can be assessed by determining the glomerular filtration rate. So normally the most accurate method measuring the rate of elimination of a substance such as creatinine through 24-hour urine collection and serum blood levels at specific intervals. But in practice, this is very difficult and time consuming. So what we use is the Cockcroft and Guntz creatinine clearance, or the EGFR. So EGFR is based on serum creatinine, gender, age, and race. It's fairly reliable for the average size patient, but it's not really ideal. I prefer the creatinine clearance, which is based on serum creatinine, gender, age, and weight. More reliable for not so average size patients, but still both of them aren't very good if it's taken into account individual creatine production, diet, and exercise. And neither of these equations are very good or suitable for children or women who are pregnant. So drugs and renal impairment, not a disease itself, but a result of underlying pathology. So if it's pre-renal AKI, some drugs that can cause this are NSAIDs, ACE inhibitors, ARBs, and diuretics. Post-renal AKI, allopurinol, sulfonamide, statins. So up to about 100,000 deaths a year are associated with AKIs. 1 in 5 people admitted to hospital as an emergency have an AKI, and it costs the NHS, AKI is estimated at 500 million per year. So if it is drug induced, it's really important that we get the dosing correct and we identify it quickly. So AKI can alter drug distribution. Urea may build up and competitively bind to the albumin. Highly protein-bound drugs will be present at a higher percentage as free active drug, important for warfarin and phenytoin. Fluid retention can have impacts on the distribution of water-soluble drugs. So then we have the last exercise. Oh, just told you what it is. But I think on your worksheet, there should be the last exercise that you can do. Okay, let's go through this last exercise. So, for 1A, a 76-year-old woman presents with considerable discomfort on urination due to a burning, stinging sensation. She complains of increased urination, 90 kilos, 5'2", creatinine, serum creatinine is 116. The eGFR and the blood system show 42 mils per minute. Calculate the creatinine clearance. So the formula we would use is 140 minus the age, which is 76, times by the weight, and then times by 1.04, divided by serum creatinine. So here we've used the ideal body weight. Sorry, I just didn't see the ideal body weight part. But because she's 5'2", she's 157 centimeters tall, and so therefore we would use the ideal body weight, and then the creatinine clearance would be 28.5 mils per minute. Everyone understand how to use the equation? Yeah. And then 1B. So the drug that we would prescribe would be the trimethoprim, orally, 200 milligrams twice a day for 3 days. The patient is not suitable for the nitrofurantoin because their creatinine clearance is less than 13 mils per minute. And there's a risk of peripheral neuropathy. So we would use the trimethoprim. So lastly, drugs in renal impairment, same principles as AKI, doses as per creatinine clearance, avoid nephrotoxic drugs. And you can have an AKI on top of CAQB. And you should always check if your patient is on dialysis. So does anyone have any questions, comments, anything they want to ask about pharmacokinetics in general? Or about those questions? If not, that's the end of the session. I hope you enjoyed it, learned something new about pharmacokinetics, found it useful. Great. I'll stop recording.